of neck in differentiated thyroid cancers. As you all know, the differentiated thyroid cancers basically include papillary, follicular, and Hurther cell carcinomas. And of all tumors, 90% of them are differentiated thyroid cancers. This is a non-hormone dependent cancer which has a female preponderance. And most of these tumors are good prognostic tumors. There are a number of prognostic criteria which has been used in these tumors. The older ones are the AGs and AMIs. MACIS is still used, but the most commonly used criteria is the ATA risk stratification system, which uses the TNM AGCC 8th edition. Apart from TNM, it also uses age. And I'll talk about this a little bit before I go on to my primary topic. The TNM classifications, the T, I will not talk much, just to say that T4 is basically the extrathyroidal extensions. And in the N classification, it has only N1, where A is the central compartment involvement and B is the ipsilateral, bilateral, or contralateral lateral neck involvement. If we look at the prognostic criteria, the young patients under the age of 55 years, non-metastatic disease is stage 1 and metastatic disease is stage 2. And stage 3, 4A and 4B is reserved for T4A, T4B and M1 disease. So if you look at the prognostic criteria, if the tumor size is less than 4 centimeters and the tumor is N1, the maximum stage is stage 2. So nodal involvement alone does not increase the stage or the prognosis of patients of thyroid cancers. If you look at the 5-year predictor of cause-specific mortality, obviously the age, the vascular invasion, the metastatic disease, Hurther cell subtypes, and the follicular carcinomas, aneuploidy is a poor prognostic indicator. 10-year survival rates, even in the high-risk group, is 76%, which is considered as good as far as the cancer is concerned. Before we move on to the neck management, we have to evaluate the neck. And USG is one of the most prominent, most important investigation that should be done in almost all cases. It should evaluate the primary, the central compartment, and the lateral neck. FNAC, guided FNAC should be done from every suspicious node, the primary tumors, and the FNAC can also be used to do a BRAF mutation in case the diagnosis is not confirmed. Thyroglobulin washout should be done if the cytology is negative. CT scan is indicated only if the disease is locally advanced or vascular or extrathyroidal extension is expected. And other investigations should be used as and when required. If you look at the evaluation of management of neck, till 2009, most of the guidelines recommended that a central compartment neck dissection should be done in all cases. However, later the retrospective studies, the evidence that emerged shows that there was no advantage of doing a prophylactic central compartment neck dissection, as it did not alter the overall survival. In 2015, the ATA modified its guideline to include central compartment neck dissection, but they say that it should not be done in low-risk patient, but other than low-risk patient, it should be done. They have not updated the guidelines. However, between 2015 and 2021, a lot of other evidence has emerged, which has led NCCN now in 2021 to recommend that only therapeutic central compartment neck dissection should be done, and prophylactic dissection is not recommended in any cases. There are 2 randomized controlled trials which has been published last year, and these are the only 2 randomized controlled trial on contranet and central compartment neck dissection. The first is by Sipple et al. The problem with this is that it was a small sample size. It has a follow-up of only 1 year. And the endpoint used by this study is thyroglobulin and ultrasound of the neck. It found no difference. at the end of 1 year between the complication rates or the thyroglobulin level or the ultrasound of the neck in any case, recommending that prophylactic central compartment neck dissection is not necessary in N0 papillary thyroid carcinoma. The second one is a bigger study, 164 patients, and it also had a 5-year, the endpoint was a 5-year recurrence-free survival. The median follow-up was 73.4 years. And at the end of this, they found that the recurrence-free survival in both the groups was same. However, in patients where no central compartment dissection was done, they had a 1 recurrence, and patients where CND was done, they had 3 recurrences. However, there was no statistical difference. Complication rate in both the groups were same. There are many meta-analyses. I'll be just talking about one, which is the last meta-analysis on this topic. And this was before the emergence of a lot of material, including the 2 RCTs, which I just discussed. They found that in patients where a prophylactic CND has been done, there is a 35% reduction in the risk of local recurrence. However, they also found higher recurrent laryngeal nerve injury and a higher permanent hypocalcemia, which was twice as common in patients where CND was done compared to patients where no CND was done. So when we look at the risk versus benefit, we see that prophylactic CND actually does not help the patient. Other things have also been looked at. Radioiodine uptake is same whether you do the CND or you don't do the CND. Thyroglobulin is reliable irrespective of CND is done or CND is not done. And current consensus is that for a N0 papillary carcinoma of thyroid, only therapeutic neck dissection should be done in cytologically node-positive disease or patient who has a TG washout showing higher thyroglobulin levels if they are cytologically negative. There are no controversies as far as the lateral neck dissection are concerned. And here too, it is only the therapeutic elective neck dissection that should be done in cytologically or clinically positive neck. The extent of lateral neck dissection depends upon the level of involvement. And a normal recommendation is that level 2 to 4 should be cleared, and some people include level 5 as well. In the current scenario, there are a number of articles which has been published this year, and they all recommend the super selective neck dissection. The people suggest that only level 3 and 4 should be addressed, as they skip metastasis to level 2 and 5 are rare. 2 is higher, about 40%, and 5 is around 5%. However, they say that if a patient has a multiple nodes in level 3 or has multiple primary nodules, the possibility of level 2 involvement is higher. Other studies have suggested that male gender, the tumor size, and extent of the tumor predict the level 2 involvement. The third study, which was published in February this year, has shown that the long axis of the lymph node, short to long axis ratio, and internal echogenicity within the lymph node predict the lymph node involvement. So to conclude, there is no role of prophylactic neck dissection in differentiated thyroid cancer. Elective therapeutic lymph node dissection should be performed if the patient is N positive, that is cytological or TG washout for central compartment, and clinical or pathological for lateral lymph node dissections. The evidence level for this recommendation is 2A. It is also seen that the lymph node metastasis and recurrences does not alter the survival in differentiated thyroid cancers. Age plus TNM is the best predictor of the outcome, as I have shown. And there are very few RCT, and follow-up is very short in those RTC due to better prognosis and outcome in differentiated thyroid cancers. For a good RCT, you require at least 20-year follow-up in a differentiated thyroid cancer, and by the time the study will become redundant. Super selective neck dissection should be considered whenever possible. Thank you. And I would also thank the organizers for giving me this opportunity to discuss the topic with you. Thank you.